just so you understand, you have to have ortho before you can have MMA surgery. And you create spaces here so that they can make surgical cuts here and here and in the palate. And it's called a three-part, and they separate the maxilla, and they advance it, and they not only advance the upper jaw, but they drop the back down so that they can rotate the lower jaw forward and up. That opens the airway. Too many surgeons don't do that. Just seeing some of the differences, you can see her palate goes from 32 to 36 millimeters. But by the way, we got 36 millimeters just with orthodontics. But the difference is in the surgery, they uprighted the roots. So in orthodontics with adults, a lot of times you can get wider numbers by tipping the molars out. But it doesn't necessarily give you the shape of the palate that you need. When you split the palate surgically, you can upright the roots and really change the whole architecture and tongue space, which facilitates the potential for airway. Just to give you an idea, I mean, the maxilla is completely separated and then fixated with screws and plates, and then the lower jaw, they not only make a cut here to bring it forward. In her case, they brought the chin forward, which also attaches to the tongue, so they're bringing the tongue forward. So they advance the upper jaw, the lower jaw, the genio, which is the chin, which is attached to the genioglossus muscle, all of it with the idea to bring the airway forward. And this is Sydney now. I think the combination of pictures are most interesting, age 12, age 24, and then post-surgery. And you can see how the profile changes. And that bolt norm is placed on the forehead in the same way each time. So it gives you an idea how far we brought the maxilla and mandible forward. And it's a group effort. So the surgeon obviously does critical work, but it has to be set up orthodontically by the dentist. We had an ENT, we did it in St. Louis, otherwise it would have been Dr. Parker. Dr. Hartman fixed her nasal septum and enlarged turbinates at the same surgery. So we had ENT, oral surgery, general dentistry orthodontics on board, myofunctional therapy with Jeannie before, myofunctional therapy with Jeannie after, and our naturopath, Dr. Christine, and Lisa helping with homeopathic things for healing. So it does take a village, and that's just before and after. And I put this in there to recognize that heart health, cardiovascular disease, a big component has to do with airway disorders. And very often it'll show up first as high blood pressure, but inflammation is caused by breathing disorders. And so we've been involved with a preventive cardiology team, Bale-Donine method, and Dr. Pritchard out of our office. And Sydney was tested before and after. There's a lot of heart disease in our family. And this is one of the things that I just wanted you to know about. It's called cardiopulmonary coupling. It's FDA approved. It's as simple as putting a ring, and they make them for children 5 and up and for adults. And it's FDA approved, so it's a real sleep study, not like an Oura ring or a watch. And you can do multiple nights because it's so easy. So instead of like a polysomnogram, which is 1 night in a hospital, we can get a picture at 5 nights, 10 nights. We can do a therapy, myofunctional therapy, MMA surgery, and see what the impact is. And so it's a tremendous sleep study tool. And then we did for Sydney's case, and I think Amy Racanella will speak to it, but with Sydney, we did psychological assessment before surgery, and then we had to wait because of American Psychological Association standards a year, and I think it was more like a year and 4 months. And we repeated 2 days of testing, which include tests that you'll know about, cognitive testing, and she'll share with you, but the changes in Sydney's cognitive abilities because she's getting better sleep is quite honestly off the charts. So we have anecdotal study of one, but it's not in a growing child. It's in a fully developed adult that if you change sleep, how much you can change cognition. And then you should know these. I'm just going to run through them. If you draw a line from a nose to the chin, that woman on the left, that is as if somebody punched her in the lower face. And it's a 4 bicuspid extraction. And by the way, she has the smallest airway of anybody I've seen. Her airway is 0.1 millimeters, meaning I can't even see her airway, and that's with her standing up. and she's a marathon runner. She's about 30 pounds. I mean, she's about 30 years of age and maybe 100 pounds, but she's really fit, and the only thing that shows up is anxiety. But as I questioned it, big time anxiety. So she's compensating well, but really not. And so, and then that aesthetic line can be tricky because in this gentleman, his chin is so protruded. When you draw a line from the nose to the chin, his lips are right on it. So aesthetic line, you would like the lips right on it, but only if you have a fully developed chin. If you have a recessed chin, it's going to give you a false look. But you'll kind of know when you see somebody like this, their maxilla and mandible are back without taking an x-ray. This nasolabial angle is really important. So if it's greater than 110, it's again an indication the maxilla is back. The lower, this is this is somebody we treated with orthotropics, and she's got a much better nasal lip angle. Arch width, you're not going to take out calipers, but cotton rolls, interestingly enough, are 32 millimeters. And so if you put a cotton roll between the two teeth and it doesn't fit, it's already going to be too small. You know, we love certainly the palates. They used to be in the 40s all the time. Now, if you got 36 and above, that would be good for modern man. But you need a better palate to get your tongue up out of the back of your pharynx so that your airway's not blocked. A gummy smile. So gummy smile is an indicator that the maxilla hasn't grown forward, it's grown down and back. And just to bring these two thoughts out, there was a series of famous experiments done by Harvald, and basically in one he put a acrylic block on the primate's roof of their mouth so they couldn't get the tongue up there. And it showed that relative to a sample where they didn't put the acrylic blocks, that there was over, I think, just a 9-month period, a tremendous change in the occlusion of the teeth. So tongue position and not being able to get it up on the roof of the mouth in primates completely altered structure. And then in a second experiment, they blocked the nose of primates, so they had to breathe through the mouth, and same thing, they saw relative to the sample group that wasn't blocked, a tremendous change in the oral structures. And so nasal breathing and tongue up on the roof of the mouth is key to developing the craniofacial complex, which we need for all those things that we outlined in the beginning. And then the upper indicator line is from the tip of the nose to the tip of the teeth. It's something that I, as a dentist, will use to get an indicator of how far back the maxilla is growing. But this is something that's more easy to observe. This is post-surgery, and if you draw a line from between the eyebrows to the bottom of the nose, it should roughly equal from the bottom of the nose to just below the chin. It should be a 1-to-1 ratio. And so when somebody's got a longer, lower face from below the nose to the chin, it's again an indicator that the maxilla and mandible are growing down and back. So long faces, high likelihood of airway disorders. And this I just wanted you to see. This is called the Children's Airway Screener. It's actually a 2-year project that's been done by a group of dentists with the ADA. To my knowledge, it's not yet released, but should be. And so it's 2 sets. It's a kind of a screening questionnaire that if there's responses such that you should take a deeper questionnaire. But there's also others that are out in terms of children's airway screening questionnaires. And Stop Bang is another one for adults. And so just, when I'm not going to read those, but who are your critical connections? That's what I was looking for earlier. It's all these people that are involved, so it really does take a community. No one of us can solve the problem. Most of the time, no one of us can definitively diagnose the problem, but working in collaboration, we can do great things. And so I thank you all for your time, and I'm going to hand it over. Thank you.